Hello everyone and welcome to today's WorkSafe Tasmania Month webinar. I'm Stephanie from WorkSafe Tasmania. Before we start, please take a moment to read the following slide about information received today. To interact in today's webinar, please use your control panel to type and submit your questions, which will be answered throughout today's presentation. Today's webinar is also being recorded and only moderator and panelist webcams will be used. It is now my pleasure to introduce today's presenter, Riley Bartholomew from Guardian Exercise Rehabilitation. Riley.
Thank you.
Oh, I'll finish the intro. Over the past 4 years, Riley has worked with Guardian Exercise Rehabilitation in providing the Tasmanian and Canberra regions with community-based treatment across multiple personal injury schemes. With the overwhelming evidence base outlining the importance of exercise and healthy lifestyle as a tool for psychological injuries, Riley and his colleagues have pushed to include exercise and whole being health as a foundational focus throughout the entire recovery process of work-related psychological injuries. Welcome, Riley.
Thank you. I'll let you finish. Thank you very much. I really appreciate being here. As I said, my name is Riley. I'm from Guardian. I've been with Guardian for about 5 odd years, starting in the Canberra team and more recently setting up the Tassie operation with our 2 clinicians, one in Hobart and one based in Launceston. So we're really excited to be part of the month and being able to share some of our expertise and experience and hopefully you find some of the content useful. Getting into it, I mean, we've already done a bit of a brief who we are, but we'll go over that really briefly. Following that, we'll have a quick discussion or a really brief overview of what an allied health professional is and what the regulatory bodies might be for such. More specifically, being an EP myself, we'll have a quick look at what an exercise physiologist is. Some individuals might not know who we are or what we do or how we differentiate ourselves compared to other allied health providers. And then the main core of the presentation today is really understanding what the clinical framework is, what it's trying to tell us to do, and what that looks like in practice, which is always a bit of a more unique task when we have some guidelines. It's easy to understand them in theory, but putting them into practice on both ends, whether you're on the employer or the insurer side or the client or the treatment provider side, what they look like in practice. If anybody has any questions, feel free to jot them down. It'll give me an opportunity to catch my breath. So if it looks like I'm going red in the face, I'm about to pass out, then jot a question down, even if it's just for my own safety. But we'll get stuck into it. So we've already heard, but Guardian is a national treatment provider who works within a wide range of personal injury schemes across the country. Each state has their own version of workers' compensation and CTP. So our teams in each capital city and a few others have a lot of expertise in understanding what the specific stresses and the requirements are for those schemes and how we can help the injured worker, the insurer, the employer, the rehab provider get the outcome that we all mutually want, which is that return to work. We are mobile, so we don't really have a clinic base ourselves, and instead we really try to push the individual to complete their program in an environment that's going to be appropriate for their pathology or their injury. It's going to be suitable for adherence and attendance. But lastly, we want them to feel like they can take control of their exercise and their rehabilitation and become totally autonomous in the long term. So for us, we think, at least in the mode that we work in, if we rely on a clinic setting and they have to come to us, it doesn't yet foster the end level autonomy that we really are trying to push for. So being mobile helps on a few different fronts. We are EPs across the country, but in WA or Perth, where the company started 20 odd years ago, we have a team of physiotherapists who have similar expertise, also conveniently mobile. So starting off, like I said, I think it's always a handy place to start, which is backtracking all the way to the beginning and understanding what an allied health professional is. I think we all know, whether it's exercise physiologist or physiotherapy or occupational therapy or even psychologists, they're probably the more common examples of what an allied health professional is. But in preparation for this, I must say I was even surprised to hear that there wasn't even a strict definition of what an allied health professional is, but there seems to be a general agreement, which you can see on the screen, and that's some health professional that is not part of the medical, dental, or nursing professions. They are university qualified practitioners with specialised expertise in preventing, diagnosing, and treating a range of conditions and illnesses, which, basing off that definition, is a pretty broad category. There's two forms of regulatory bodies which you would always hope for in health. Is you want to make sure that professions or professionals are keeping up to date with best practice, with research, government guidelines and recommendations. So we do have the Australian Health Practitioner Regulation Agency. It's a bit of a mouthful, but we call it AHPRA. And then secondarily, a lot of professions have their own governing body who are responsible for scope of practice, standards, compliance, adhering to research. And you can see on this list here that there's a convenient list of which ones are which. So from AHPRA, there's quite a broad category, or there's a broad range of different practitioners who would be viewed as allied health professionals under AHPRA. And then on the right of the screen, we have the self-regulated professions such as EPs, sonographers, social workers, speech pathologists, dietitians. But to bring it back a little bit closer to at least what my experience is, being an exercise physiologist, up the top you can see, I guess, the tagline from our peak body, which is Exercise and Sport Science Australia, or ESSA. The requirements to become an EP would be the successful completion of a 4-year tertiary program that meets the standards or the requirements of both ESSA and the AQF at a level 7, which is that bachelor's degree. And along with that specific coursework, students are required to complete 500 hours of clinical practice throughout their placements in their final 2 years. And those 500 hours are typically broken into 140 in what we'd call a healthy population, where the aim of the intervention is preventative medicine, improving health and fitness, general well-being, and that prevention of chronic diseases. And the final 360 is a lot more clinic-based, a lot more clinical focused, where we're working with individuals with a pathology of some variety. And you can see that on the screen. The role of an EP is pretty broad, based on our expertise or the education we get from university. It means we're able to be of assistance for a broad range of people with a wide range of conditions. So I think the scope of practice is the easiest way to kind of put a bubble around what our roles and responsibilities are. You can always look this up on the ESSA website. It's certainly nothing that they're hiding or protecting. It's pretty front of face. But it is important to note that the scope of practice document, like most health professions, it's a minimum. It outlines the minimum core duties that the health professional is able to undertake as part of the regular duties, because a full detailed list really is dependent on the clinician and is normally pretty regularly impacted by further studies, extended scope that they might have completed, interests, expertise, experience. So clinician to clinician, the scope really does vary, but for the basics, you can look at the scope of practice document. Generally though, an AEP's interventions are going to be exercise-based. Of course, that's our main tool, that's our bread and butter, that's what we have the most knowledge in, as well as education, lifestyle modification, general wellbeing advice, supporting behavioural change, and then even supporting wellbeing through mental health and behavioural change. Getting into, I guess, the main part of today, the clinical framework. I'm not too sure how many people have heard of it or have read it. Again, jot them down in the chat or in the questions if I'm going too fast or if I'm skipping over things that I might be assuming is general knowledge. But what we know is that the clinical framework is a really handy guide that unifies what the approach should be for any treatment provider, regardless of your health profession, when we're working with someone with a workplace injury. I think the core tenets of the clinical framework, which we'll see shortly, are pretty they're generic enough in a good way that even if you don't have a workplace injury, this is what the research suggests should be best practice care. So despite it being written really specifically for compensable injuries or personal injury schemes, I think they should be universally accepted as best practice. It's not the best picture, but on the left you can see who has become a signatory or has put their support behind the clinical framework. And as you can see, it's pretty much every state and territory and the relevant regulatory bodies. Getting into the 5 principles of the clinical framework. The first being measure and demonstrate effectiveness of treatment, adopt a biopsychosocial approach, empower an injured person to manage their injury, base treatment on the best available research and evidence, and then implement goals focused on optimizing function, participation, and return to work. I think they all sound pretty common sense. That, it doesn't sound like there's anything really groundbreaking when you look at those 5 core tenets, but what we do see in practice is there's a disproportionate focus on perhaps the clinical aspect of someone's recovery. So clinicians and specialists and GPs will do an exceptional job at focusing on I guess, the front-facing work that a clinician has to do day to day, but perhaps the broad breadth of what these core tenets are trying to push people to do, or what these principles really should, what are outlining people should do, aren't given the same amount of effort as that front-facing clinical stuff. So starting off with the first one, I think the key to the process of graduating a return to work or the return to work of an individual with a personal injury is that we need to demonstrate that they have an improvement in capacity. I think that's, again, pretty obvious, but all stakeholders have a vested interest in seeing these changes. So measuring at the beginning, during, and at the end is really important for the return to work of the individual, as well as, the general, it's generally the most best practice, I guess, in injury management. Unsurprisingly, though, measurements need to be appropriate to the person, to the injury, and to the role. So having an assessment or using a tool that's only valid for a really narrow focus may be relevant in theory or in the research, but how that translates to someone who has a unique role or is part of a unique population group or has, really challenging psychosocial stresses might be a little bit tougher. So the assessment tools need to be considered, I guess, in that aspect. Fortunately, it's not as if we have a shortage of options on how we can do these measurements. We have a broad range of screening tools here. It's just truly only a fraction of the available tools that are validated as appropriate, some of which are diagnostic, some of which are simple symptom checkers, some of them being really multi-categorical whole being tools. And then aside from the screening tools, the questionnaires, of course, we have those physical assessments. And again, considering the injury, the person, and the job. Then with all of that, I think communicating it is the next obvious step. We can't just do the assessment and then sit on it like a pile of gold. The information that we gather from these assessments needs to be provided and shared with all the relevant stakeholders involved in the return to work journey. This is an example of someone who one of the Canberra team had worked with 18 months or 2 years ago, just looking at the date. And what is important is that any report be really rounded and holistic and not just pathological. So you can see here we have the psychosocial considerations identified, which again in the return to work journey is important to explain and identify what other contextual background confounding factors might pop up and how we're going to address them or how we need assistance in making sure the person can engage in their treatment. So keeping it rounded is really important. This is just the last few pages of the same report. And the last thing to note is, again, we have the results of what an assessment might be, But more importantly is the comment or the interpretation of what these reports mean. So whether you're an exercise physiologist or a psychologist or a physiotherapist or any other health profession, our clinical expertise and our clinical judgment and how we can interpret these reports is probably the most important thing in this report, or equally the most important. For example, if we have a young, 20-year-old who's a landscaper, having a goal of, having a capacity of 20 kilos of being certified as lifting 20 kilos, that might not be enough, for someone who is expected to lift a wheelbarrow full of bricks or pavers or, carry bags of cement. Whereas if you're an individual who's in administration or an office worker towards the end of their career, 20 kilos might be sufficient. Like, we don't need to push it any further than that. So I guess having the context of the broader requirements for this individual makes a big difference in how we can assess if someone is making good progress, if they're plateauing. The second one is to adopt a biopsychosocial approach. And if you don't have a health background, I think this phrase probably sounds like a bit of medical jargon or kind of a mashup of totally unrelated words or context. But what we actually see is it represents probably the biggest differentiating factor of how treatments are viewed and how they're supported, and how claims can progress or how relationships can break down purely by this kind of biopsychosocial approach. And it might feel like a really kind of fresh or contemporary approach that the Scandinavian countries are at the forefront of implementing, as they often are, but it's actually been around for many years, many decades, and was first used in general health care management. The best example I think of where it's really well accepted and understood is more and more if someone is going through their cancer journey, obviously they'll get the standard treatment, whether it be radiotherapy, chemotherapy, or surgery. But surrounding that individual, there's often dietitians who are involved, psychologists, obviously the significance of such a diagnosis and treatment, as well as exercise physiologists or lymphatic drainage specialists, all these kind of people who are going to be part of the team to have a really rounded support network and help this person get back to where they need to be. So that's one example of where the biopsychosocial approach is really well accepted and understood and starting to be implemented. But what we see in practice, and especially in someone who is experiencing persistent or chronic pain, is that it might not often be the case, and also with primary psychological injuries, they'll obviously get the psychological support and maybe the social support, but how their injury is affecting their physical body might not be as respected or as offered the support. I just put this quote in because I thought it was interesting to see that the International Association of the Study of Pain are really acknowledging that there's the actual or perceived tissue damage part of pain, but then also the interpretation of the sensory, emotion, cognitive, and social components. That really all does wrap up in what pain really is. I just thought that was a nice little example. Nice little picture. So if the biopsychosocial is what we should be doing, I guess it's in opposition to what we'd call the biomedical model, or a pathoanatomical model, or a really medicalized or clinicalized model of care, which more simply, and often is what people make the assumption of, is that pain or illness is related to strictly a structural damage, chemical imbalance, dysfunction, requiring surgery, and that's it. I think having that binary approach really omits 2/3 of what the person is going through and what the injury could be fueled by. So that biopsychosocial, or the BPS approach, really does kind of round it out, explains that there's a really complicated relationship between people's psychology, their health literacy, their biology, and it makes it complicated in how the person experiences the world. But just to be clear, this is not the biopsychosocial approach. It's not something that is, 3 siloed train tracks of treatment where one person does the bio, one person does the psychological, and then the return to work provider or the vocational consultant does the social aspect. That's not at all what we're trying to explain. Instead, what we need to respect is that it is complicated. It's really dynamic. There's a lot of intertwining things that will change someone's experience. But chiefly, the person who's in the middle of it, they're the one who has experienced it. So getting them to help guide us through what they're experiencing and what they need is the crucial part of that biopsychosocial approach. To help understand and identify what people might be going through, it can be hard from the outset, especially if you don't have a health background, or if you're only involved as the return to work coordinator or in the insurer. You're kind of within your lane, which can be hard to step outside of. But there's this flags model, which is a really helpful framework to help categorize or understand what someone might be feeling or struggling with. And then you can see on the left there, some people might recognize the Arebro. There is quite a few screening tools where they're written and they've been validated as a multidimensional tool to help identify multiple flags. So not just the biological components relating to pain or symptoms or dysfunction. There will be questions relating to their sensation of anxiety, their withdrawal from social life, how they're engaging with their hobbies. I think all of that is a really significant part of someone's recovery and can lead a lot of information to us as to how they're coping or how they're going to cope or be compliant with their ongoing treatment. So we have the Arebro, I think I said the RAND short form 36. We have the Promise 10. Some of these are really interesting kind of multi-categorical, multi-dimensional questionnaires, which we often use. Give us a lot more information. The third point here, if I can pick any of the principles that is probably, and unfortunately, the most insidiously undercut by a lot of treatment providers, whether it's surgeons, GPs, allied health professionals, is this empowerment kind of tinge. The aim of the game is to empower someone to look after themselves and to be autonomous with their care, and often that's not what we see. And I think the best way to imagine this is, we really want to fuel the furnace of a locomotive so that once the fire is roaring, it's going to continue down the tracks, whether we're continually adding fuel to the flames. It's going to keep on traveling under its own steam. We want people to have that health literacy to continue themselves. And for us and how we try to do it, again, knowing that our background is in whole being health, we put education at the forefront of what we want to do, and that doesn't just mean that we throw a textbook. It's got to be contextual and timed appropriately for what they want. But ongoing education related to their condition or related to the barriers that they've identified as a challenge is only going to be beneficial for how they can understand themselves, what they're struggling with, and how they can, in the future, manage it without needing that external support in every aspect. A lot of these resources, or all of these resources, in fact, are on our website if anybody is interested. They're all freely available. The guidebooks are 20 or so pages, with each page being kind of a single topic. But what's important is that they're written for the consumer, so there'll be references down the bottom if people are interested. But for the most part, it's written for the person experiencing that symptom, so it should be easy to digest. Education leads to self-efficacy and how people feel confident and capable of managing it themselves. There is a lot of research in how self-efficacy can be a predictor for someone's return to work. And here are just a few snapshots that we found from the literature. There's a few slides in the next few slides where there's just a whole lot of quotes. They're mostly in there for people who are either watching this later or are going to download the slides if they want to look back at. But this one I thought was really interesting because it specifically relates to the return to work outcomes for an injured worker. But self-efficacy, the belief about one's ability to undertake behaviours to achieve desired goals, has been identified as an important factor in the return to work of injured workers. And I think that makes sense. A person who has high self-efficacy is going to view a difficult task as something to overcome or to master. We see that in the literature. They're going to attribute any setbacks to not enough effort on their behalf or not enough knowledge, and they're going to be thirsty to dive into that and understand more. And they're not going to feel overcome by by decisions. They're going to feel more control, and they're going to feel less threat from activity. Whereas someone with low self-efficacy is going to be quite avoidant. They're going to see exercise as painful and something that's a threat to their health, and so they'll continue to avoid. They'll dwell on obstacles. They'll ruminate is a really common one. They're going to give up more quickly and face difficulties, or when faced with difficulties. I mean, that's all pretty broad, and I think it's not always that clean cut. I think we can all acknowledge that some people have a bit of both in their personality and how they view things, or there might even be inconsistencies with how they view treatment. They might have really high self-efficacy with one form or function, and then maybe low self-efficacy with another. But in a nutshell, for an exercise physiologist, our goal or our job is to really encourage and provide positive reinforcement that activity isn't something to be avoided. It can be managed, and we can use our clinical reasoning and support the person to graduate their activity. But restricting activity is not the way to view it. We want to build confidence in their ability to perform a task and a movement, and not, again, like I said, restrict that activity. And we want to improve coping strategies and develop what we call a flare-up plan, instead of reinforcing that activity and pain is to be avoided, and to ignore or to avoid anything that could be painful. Because again, we know in the literature that avoiding painful stimuli doesn't lead to recovery, in a lot of circumstances. This is also a really cool graphic that I think explains the importance, or the relationship between importance and confidence. The goal is to have people kind of, right through the middle, where they know the importance of activity or change, and they feel confident to undertake it. What we don't want is people who see the value or the importance of the activity but have low confidence. Often that's the people who have that relationship, or that they foster a dependency on their treatment team, where they obviously know the importance, but they just can't do it themselves. So we want people to kind of get to the point where they're ready to make those changes independently. I think this is an interesting one. Effective goal setting is, of course, a vital part of the process, both for the injured worker to get their own buy-in, and how they measure their progress. But of course, for the employer, the return to work provider, the insurer, we all want to make sure that we know where the goalposts are and that we're all kind of kicking that way. I put an asterisk behind that second point because there's a lot of research and a lot of supplementary information that has kind of come out in the last 5 to 10 years, which suggests that SMART goals might not be the most appropriate for everybody. They obviously have their function, and they're a very handy tool to articulate what we want to get out of someone, but for everybody that might not be the case. And again, here's one of those slides where I don't expect you to read it all, but what the research suggests is we need to have a more person-centered approach, and understanding that people are different is going to be the way of getting their buy-in and getting people to become adherent to their own program. So what that looks like in practice, at least for our clinicians, as that will inquire and evaluate an individual throughout their assessment to find out where they sit in these stages of behavioural change, where someone who's in that pre-contemplation stage, they're likely to not know how to set a SMART goal. They're probably not going to be able to set one themselves, and even trying to assist them in setting may not lead to something that they care about. And then also they're not going to have the buy-in, so it's probably not going to get done. So instead, what we'd call a stepped goal approach is what's going to be the more appropriate for getting them to engage. And goals don't have to be as simple or tokenistic as that SMART goal, where it's this person is going to lift 20 kilos 4 times by 12 weeks. I think that doesn't really mean anything. It might satisfy the case manager or the return to work provider, but that doesn't mean anything for the injured worker. So making sure that we can translate into something that's important to them, and if we need to, we can step it out to the immediate goal is just to participate, and then the goal in 4 weeks is to be able to demonstrate X, Y, and Z, and then all the way up to 10 to 12 weeks might be the actual end goal, where it's independence, it's autonomy, it's return to work, it's engaging in their hobbies. It could be a wide variety of things, but breaking it up into smaller chunks is probably going to be more palatable. We're going quicker than I thought. The fifth one here, I think it's a bit of a tricky one because I don't know of a health provider who doesn't think that they work off the evidence base. I think everybody thinks that they're an evidence-based practitioner, but again, what we see in practice is that's not always the case. What makes it hard though in that, and in being devil's advocate, is that health professionals often work not in opposition, but we have our lane, we have our expertise, we have our knowledge and skill set, and sometimes they can be contradictory. That's the nature of health and humans and science is, although the research can be aligned to what is consistent, professions and professionals and health can sometimes not be that clear cut. For anyone who isn't scientifically minded or comes from a health or a science background, this is just a simple kind of cartoon to explain the hierarchy of quality of research or of evidence, with opinion and anecdotal evidence being the bottom, the least powerful, and then those systematic reviews, RCTs and meta-analysis right at the tippy top, where those final two, the systematic reviews and meta-analysis, is what does or often informs best practice and what informs policy position stands. What's hard though with this is, of course, we want to stay up here, but day to day, our clinical reasoning and our clinical expertise is this. So day to day with patients, this is what we have to go off. We'll use what we understand about best practice coming from these top three, and then understanding the individual. That's where we have to mix kind of these top three, what we know in the literature, what the consensus is in the research, and our own clinical judgment to what's going to be appropriate for the person. So although this is the quality of information, it's not to be confused with what we see day to day in terms of client interaction. Just keep that in mind, it's not quite that simple. I was really conscious that I didn't want this to be a really research or clinic focused presentation. So I only took two little graphics that I thought would be interesting. On the right here, this is a snapshot out of the Royal Australian and New Zealand College for Psychiatry. It's a mouthful, but it's out of their guideline for how they manage mood disorders, or how the college recommends the management of mood disorders. And what I think is really interesting and important to note is that step 0, so not even step 1, but step 0, they're recommending lifestyle change, regular activity, healthy diet, avoiding substances. That's their step 0 or their step 1. Then it progresses into talking-based therapy, pharmacotherapy, and then anything that's more extreme after that. I think we see this is often not the case. Often people start with, and which is fine, a referral to a psychologist or a counsellor or a social worker. They're provided pharmacotherapy concurrently, and then perhaps they progress into something that's a little bit more, extreme isn't the right word, but a little bit more in depth. And then, you know, as an adjunct or as a side note, they might be offered a conversation about lifestyle change and exercise. But again, using that biopsychosocial approach, it's the whole person. Everything needs to be looked at if we're going to get effective change. Important to note. On the left here, this is from the British Journal of Sports Medicine, which is for a long time been the gold standard of what health professionals, whether you're physiotherapy, even orthopedic surgeons and exercise physiology, what we would go to for advice on musculoskeletal rehabilitation. I think this is a really handy kind of myth-busting tool or a bit of a guide, but you know, obviously the person is at the center. We see here that they value the screening of both red flags and then those other secondary or concurrent psychosocial factors. This is an important one. Imaging should be discouraged where necessary. So if there is any red flags, that's when you progress into recommending some imaging. But if someone has got what we call a non-specific lower back injury, they probably don't need imaging. What we see in the research is it doesn't improve outcomes. Regular scans, of course, outcome measures like we see in the clinical framework. Education is valued in all sense of the word. Empowerment is important. We want them to continue with activity as much as possible. So again, prescribing bed rest is really old-fashioned. We don't recommend that whatsoever, because I think the view or the insinuation is that people are weak or they need to be protected. But what we know is even with an injury, even with a lot of chronic diseases, activity should be recommended. again, using our clinical judgment to prescribe and avoid risks, but activity is typically recommended. In terms of that best practice approach to therapy, this is a really divisive one, but manual therapy is only an adjunct to other evidence-based treatments. So if people are getting solely manual therapy, whether it's massage or deep tissue therapy or cupping or dry needling or acupuncture, what this suggests is, while that might be effective, as a sole treatment, you're not going to get the outcome that you would otherwise if you use it in conjunction with other therapies such as exercise, education, lifestyle change. I think that's an important one. Apart from the cost to the insurer, also to the person, the medical or the health system across the country, we want to stay conservative for as long as possible, and that means avoiding surgery where we can. You can always have surgery if you need it, but if you have a surgery, that's trauma to the body. You can't come back from that. So conservative treatment is generally what's recommended. We know the good benefits of work and how work is a vital part of our health and well-being. So returning to work, again, in a suitably graded way is a really important part of someone's recovery. Does anybody have any questions? I don't know if there's any listed yet, otherwise I can keep on going.
No questions have come through, Riley, so yeah, please keep going.
Wonderful. This is another slide that I dropped in for the people who want to come back and have a read. If anybody has worked with Guardian, they'll know that we have a real passion for supporting psychological injuries or people with mental illness. Again, because we know what the research suggests about the effectiveness of exercise and lifestyle change and education. That's not what's provided, whether it's in the general health care industry, but it's specifically within personal injury. That approach, that person-centered biopsychosocial approach, where it's a multi-pronged or three-pronged approach with pharmacotherapy, psychotherapy, and what we call lifestyle psychiatry. That isn't yet the norm. I think it is getting better, and we're trying really hard to work with insurer groups and regulators, and have had some really significant outcomes on that front. But for the most part, the general consensus, or the general approach at the moment, I should say, is that pharmacotherapy and psychotherapy. But like I said, the research suggests that we need to do more, and we can do more. We've already touched on this a little bit more, but when we spoke about that biopsychosocial approach, but when it relates to pain, it's complicated. It's really not as simple as tissue damage. If it was that simple, medication would be a lot more effective, surgery would be a lot more effective, but it's not always the case. And what we know is that pain is a really complicated system. You don't have pain receptors in your body. You don't have pain fibers that run from your joint to your brain. It doesn't work like that. It's a lot more complicated. And so we need to be more diligent with how we can explain and more consistent with the framing of what we put to people as recommendations, I guess, simplistically. I don't know if anybody has heard of that cup analogy. You can see there's a little graphic, but it's a really handy tool where we say, if your tolerance is a cup, whether that be emotional health, whether it be a physical tolerance is a cup, everything fills that cup. You can, drain the cup if you know how to manage yourself, and if you can vent your frustrations or vent your tension in your body. If you've been sitting down for a long time, you kind of stand up and you do a little bit of dance. That might be how you manage your cup. But if the cup overflows, that's when you're going to feel it. So if your cup overflows and you have an emotional response, that could be the trigger. Or if your cup overflows, you might feel pain. So there's a lot of things that implement and that'll fill that cup. It's not just as simple as movement or being sedentary. Really coming towards the end, but I think this is what we would recommend as the ideal client journey when we're talking about whether it's CTP or workers' compensation. But the client journey should be a referral from the medical professional, or whether it's a return to work provider, rehab provider, employer, insurer. I think everybody has the capacity to make a referral, and of course the GP will be the final call on where it's appropriate or if it's appropriate. But a referral is the first point of call. The clinician can have a discussion with all the stakeholders involved in the return to work process to understand the background of the claim, the injury, the treatments to date, any contextual barriers that might need to be observed before they engage. They'll complete that initial assessment to understand that whole person, so keeping it biopsychosocial even in the assessment. That report will go out to all stakeholders so that there's consistency in understanding. Everybody knows what the clinician is thinking and what they're recommending. Our program is developed with the clinician's judgment and the client's buy-in. I think, again, we're not going to prescribe a program that we think is the most appropriate without their buy-in or without their input, because we want them to be compliant and we want them to enjoy it for the short term, but also for the long term. So their involvement is really important. Throughout the process of the consultations, we'll have, it might start weekly, but the goal is always to push the sessions out from weekly to fortnightly to once every 3 weeks or 4 weeks. Again, we want to instill that sense of autonomy, self-efficacy, and less of a reliance on the clinician to do the work. And throughout that process, we're going to provide regular updates to all stakeholders as to what attendance is like, what compliance is like, what buy-in is like, if they're improving, if they're not improving, if they've mentioned something that's would be a psychosocial flag, we can put that into the recommendations or the updates to the other stakeholders as something to be wary of. Where necessary, I think it's important that treatment providers make themselves available for case conferences, medical reviews, again, to make sure that everybody's aligned with where the goals are and are all aiming towards the same goal. A final consultation will be to wrap things up. It'll be to kind of tie up all the loose ends, but it really should be that final push and recommendations that people become autonomous and continue independently. I think if someone does have a musculoskeletal injury, the program might be really geared towards rehabilitation in inverted commas, but by the end of it, I'd hope that they want to exercise for the long term because they enjoy it and they see the health benefits, and not just stop after they return to work or return to life. And in that final report, we'll often do, or what should happen is a final assessment where we can provide a report back to the stakeholders to comment on improvements in capacity, which should, and hopefully, and again, ideally, lead to that return to work or return to life. Going back to the start, I think for people who may not be as aware of what an exercise physiologist is or what we do, it can be hard to understand where we fit into the picture, especially with other health professionals who have been around for many more years or decades. Exercise physiology isn't yet part of BAU, but I put up on here a few triggers that might help you understand when an EP might be a valuable piece in the puzzle for someone's recovery. I think often what we see is that if someone is out of that acute phase of their injury, so that might be the main differentiator between, say, an exercise physiologist and a physio, but once you're outside that acute injury, I think an exercise physiologist is appropriate because we can provide that longer term, that education, lifestyle change, progress their program into something more active. If there's mental health or other psychosocial flags involved, then an EP might be a valuable piece of the puzzle. If symptoms are insidious, or if the onset was insidious, I should say, then an EP might be valuable as opposed to a traumatic injury. And there's a few other ones on here. If motivational empowerment is the focus of the treatment, if someone just seems to have plateaued and they're kind of dwindling and the motivation is waning, then perhaps an EP that has a bit more room to move in how we can prescribe rehabilitation or program and activity, that could be a really useful tool. That's pretty much it. The final slide was just any questions or feedback, but I thought I'd leave it here so that people can have a read. Is there any other questions that anybody has?
Yes, a question has come through, Riley. So my experience of working with insurers is that they appoint a rehab coordinator to link stakeholders. However, it is the GP who makes decisions as to what treatment is required. Despite several worker back injuries, an EP has not been included in treatment plan. Why doesn't the coordinator or GP go down this path?
Yeah, look, I think that's a really common scenario. We see that, in the Canberra team that has been around for 5 years or so, that still comes up quite a bit. I think there's a few reasons. I think chiefly is because EPs are just not as well known, and what we do isn't as well known or respected as, say, a physiotherapist, which would be synonymous with rehab. So people will, for the most part, go to a physiotherapist, and the GP will recommend that. But translating that into, or progressing that into exercise physiology, if the person is progressing or if they're not making any traction, that doesn't really come up all that often. And I think it's because the lack of awareness from medical professionals, or the lack of willingness from patients, the lack of referrals sideways. Often we see that, and it's not always the case, of course, but some clinicians are unwilling to let go of their patients, and that's kind of what I was referring to with that that insidious undercutting of fostering that empowerment. We want people to leave us. Like, we don't want to be continuing with them long term. So I think it's, of course, it's the GP's responsibility to take charge and make those recommendations. But each stakeholder has the ability to make a recommendation. It would be then the GP's responsibility to make that final call. But that biopsychosocial approach refers to everybody. So whether you're the treatment provider making recommendations that might be against your treatment, whether you're the employer who sees that someone is struggling with their mental health following a lower back injury, whether you're the return to work coordinator, or whatever it might be, we all have the capacity to have that humanistic insight into what a person is struggling with. So we can all make a recommendation, and then we can lean on the system to kind of pull those levers. But to answer your question, went sideways a little bit, but to answer your question, I think it's a few different reasons. It's a lack of awareness, a lack of understanding of what an EP could do, and historically, it's been a very passively run scheme where exercise is rarely recommended. Again, it's an old school approach, but the recommendations have historically been to rest if you have an injury, or to avoid activity, which, like I said, we know in the research it doesn't lead to an outcome we want.
Right, thanks, Riley. There's still time for everyone to submit any questions to our presenter today, Riley Bartholomew from Guardian Exercise Rehabilitation. Please use your control panel to type and submit those questions. Today's webinar is also part of WorkSafe Tasmania Month. WorkSafe Month runs throughout the month of October here in Tasmania. It's also part of National Safe Work Month as well. So do also head to the Safe Work Australia website to see what other events and activities they're running, as well as to worksafe.tas.gov.au to see what other webinars we are running this week, and then in-person events from next week as well. Riley, is the main difference between an EP and physio is that the EP takes the holistic approach?
I think in practice that's commonly seen, but it shouldn't be. I think the main difference is if we go back to basics for two students who are about to graduate uni, so they haven't got any extended scope or pre-existing experience, we will do the same degree for the first 3 years, and then in our fourth year is where we really split off. The main difference would be a physiotherapist who's got the tools and the expertise to really work in that acute phase of an injury. So if someone has a traumatic injury, or they roll their ankle and it's kind of black and blue and swollen, that's certainly the domain of a physiotherapist. They have the skills, they have the expertise, they know how to more passively and more gently assist someone's healing and recovery journey. Whereas an exercise physiologist should and often is involved from the subacute. So maybe 5 weeks after an injury is when we can start to be involved, through to chronicity is when an EP, in a musculoskeletal sense, has their value. That biopsychosocial approach should be given to everybody anyway. And even if someone has an acute injury, often, and I was speaking for my team, or for our team, we often get a referral concurrently with a physiotherapist where they'll do some of the more textbook treatments, but the surgeon will, or the insurer will, refer to us for education, activity recommendations, making sure that they're keeping up to date with whatever keeps them mentally well. So we'd be working in tandem. But that doesn't mean it has to be an EP. I think an EP is uniquely well suited for it. But again, everybody can and should be doing that.
Thank you. With no further questions coming through, Riley, I'll begin to wrap up today's webinar. So thank you to our presenter, Riley Bartholomew from Guardian Exercise Rehabilitation, for today's webinar. Today's presentation as I have said, as part of WorkSafe Tasmania Month, do head to worksafe.tas.gov.au to see what other events and activities we are running throughout the month of October. Today's webinar has been recorded and will be made available shortly on WorkSafe Tasmania's YouTube channel. So thank you to Riley and thank you to everyone for attending today's webinar.